think I got that. Someday I'll figure out how to do all of this really nice and seamless, but today ain't the day. All right, I got a few more seconds here. I'm gonna take a sip of water because it was a little dusty. Hopefully I'm not coughing, but I couldn't really feel it coming on. So bear with me, everybody. Thank you so much. Thank you for joining me. If you're joining me live right now, again, my name is Adriana. I'm a doctor of physical therapy. I specialize in pelvic health here in Southern California, and I started this little channel, whatever it is that YouTube calls it, because I am just really, really excited to share whatever I can with you. So Pelvic Grand Rounds is definitely a passion project, a way for me to hopefully be able to connect with somebody who is excited and or even just curious about pelvic health. It is a great specialty within uh, physical therapy, within occupational therapy, and I'm really happy to see so much of this, just pelvic floor, addition to even like exercises and boot camps and things like that, because it's really, really important. And we can't skip this part of our health and our body. So, anyway, like I said, welcome. I do have a series this month. It kind of overlapped a little bit with October, because it was at like the end of the month. But this series is focusing on what is, are conditions that we see in the clinic, are they, especially like orthopedics, outpatient orthopedics, when we see them, are they just purely orthopedic conditions, or could there be a pelvic component? So the series is called Is It Ortho or Pelvic? Last week, we dived into the operator internist. I did have a couple of treatment um, videos there that I embedded. So go back and take a look at that round, or that episode. I don't know what to call it, and check that out. See if you can use it with a patient. And it's, I think, a very important component to just pelvic health. Anyway, this week is, does your patient really need a total hip replacement? Okay. And this is, again, like every other topic, it's going to be loaded. We're only going to cover, these sessions are only going to be 25 minutes. So I won't be able to cover everything that I feel we could look at, assess, treat, and, yada, 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 simply because there's just not enough time. But I hope that this little bit of information will help you just kind of think a little bit about what may be also going on at the hip. Now, the reason why I picked the hip is because of its proximity, of course, to the pelvis just in general, but also because it is one of the two joints that has the most surgeries performed. So total knee replacements and total joint replacements are incredibly, they're just big in volume in terms of how many are done in the United States. And knees are done more popular. And then right after that is the total joint replacements. Okay. So these are, and if you are a clinician, you know that, the joint is replaced. It is no longer, a natural part of the body. People do tend to do really well after these surgeries. They feel less pain. They're able to move better. But there are a lot of people who, even after having a total joint replacement at the hip, continue to have discomfort. Okay. And some of these patients perhaps needed to see a pelvic floor therapist or a pelvic health therapist prior to having surgery or right after having surgery. So I can go on and on about what they need after the surgery. I'm not going to cover that this time around, maybe some other day. But prior to a hip replacement surgery, it's my belief, and I do feel very strongly about this, that patients should have prehab, so should be getting some sort of strengthening, range of motion, some sort of program going to make their outcome after surgery the best. But also, we need to ensure that we are looking at all of the possible structures that could be referring pain to that joint area. Okay, so if I move forward here, perhaps, yes. So just a little blurb, and I kind of covered that, but per the CDC, hip replacements have more than doubled in terms of their prevalence since the beginning of the century millennium, so 2000. And it is projected that by the year 2030, per year, there will be almost 1 million total joint replacements of the hip. And this is because we have a population that is aging. You know, we are definitely seeing that the generations after the baby boomers have just had less kids, you know, and we have more of those baby boomers now than, you know, Gen Alpha, Gen X, I'm pretty sure more than the millennials. And so as they, you know, age and use their body and have that arthritis that is now setting in, they're going to be seeking uh, assistance, help. So treatment will be, for a lot of them, a surgery. So just so that you know, that is what's going to be coming in through the door. It's going to be the people that are having the hip pain, the knee pain, and you will be seeing a lot more of them. Okay, so the clinical presentation, I wanted to do a little bit of a comparison because there is some overlap. Me as a pelvic PT, I can see, you know, pelvic symptoms and anything, you know, you sneeze, it's your pelvis. No, just kidding. But there is a lot that stems from that general area just because it's a pretty big, you know, bony prominence. There are a lot of attachments there. And some of those attachments are going to present themselves as, you know, potentially a diagnosis like hip OA. So covering hip OA, okay, so osteoarthritis. What you tend to see is people complaining of pain, and that pain distribution is typically at the like anterior medial joint line of that hip. So people say, you know, it's almost feels groiny. It really does feel like it's like cutting up, you know, and I really can't stand it. Some people may describe having some like you know, posterior hip pain as well. So the back of the hip. Every now and again, I have people saying that the side of the hip, you know, the lateral component of that hip hurts. But with that walking pattern that's completely off and, you know, funky, you're going to end up with some, you know, bursitis or something going on that's going to just make that entire hip overall feel uncomfortable. Okay. The type of pain is like that deep aching, and you know, they feel it with walking, they feel it with sitting for a long period of time, and it's just super, super uncomfortable. All right. Their range of motion. So this is where you can really tell that something's going on with the joint space itself, because that joint is not going to move well. And if you are a PT, you know that that internal rotation is going to be pretty limited. Flexion is also going to be limited. And basically all around, it's going to have some discomfort with movement, okay? Weight bearing on it also tends to be uncomfortable for patients. And then there's like some crepitus you hear it more at the knee than at the hip, but you know, at the hip, when they bring it up and then they bring it, you know, they flex it and then they extend it, you can really tell when there's like clunking and there's grinding there, and you just feel like, okay, all right, you've done your best, we have done all we can do, let's get you a new one, right? So for that's, you know, one group of hip OA. For the people, or for let's just talk about, like, I guess the I'm all over the place right now. Let's just talk about the pelvic attachments and how they may present. Okay, so we've got one presentation of hip OA, and I've got, you know, one presentation of pelvic you know, pain. And it's daylight savings time. That's why I already feel like I need to go to sleep. But anyway, pelvic attachments, okay, those can refer pain as a deep aching in the pelvis as well, okay? Lots of different presentations, but let's concentrate on the stuff that may overlap with the hip OA, okay? You have deep aching into like the hip area as well. Now this can be anterior and this can be posterior as well, okay? And sometimes with like that posterior, anterior, you're looking at the like hip internal, hip external rotators that could be the source of a problem. With range of motion, you're not going to really see a them affected unless it's due to just the patient being highly reactable to it. So moving the hip joint usually doesn't, you don't feel the crepitus, you don't feel that like joint stiffness, you don't feel that hard stop that you typically find with the hip OA, okay? But if you look at these two things, and I'm going to be concentrating on pain with these two, simply because we often will, I guess, program our treatment plan based off of where patients are feeling their pain. And often, a lot of surgeons will also recommend interventions based off of the pain, okay? I have had, I don't know, at this point, probably thousands of joint replacements that I've treated. And I have heard from tons of patients that said, hey, my joint was never really too stiff to begin with. I was just, I just had pain. And it had been going on for long enough that I was like, yeah, let's go ahead and get this done. And, surgeon was like, yeah, let's go ahead and do something about it. And they did okay, right? But I do get quite a few, and specifically women, patients that after surgery, that groin area continues to hurt. Okay, they continue to have discomfort, they continue to have pain, they continue to report, if maybe not the same severity of the symptoms, still some ongoing stuff going on in that anterior medial portion of the hip. So when I see them and, they come for an assessment, sometimes it's incidental, which is kind of interesting because they'll be coming in for something else and they'll mention, last year I got my hip replaced and, this is, I've got this bowel stuff or this bladder stuff going up. I also still have some hip pain going on. And we assess and we do our thing and they're like, should I have come here before? Because the places that you are palpating, the things that we are doing are definitely reproducing some of that pain that I was having even before the surgery. So I am thinking I should have been coming to pelvic PT prior to. And they're correct. They should have been coming because we get to see those internal structures, okay? So the presentations, pain, okay? With true hip OA, you get that joint replaced and people are like, this has saved my life. With those that perhaps had referrals coming from the pelvic floor or that perhaps that was the pain, you're not going to have a ton of changes or significant changes, or you're not going to take that pain completely away if you aren't, addressing that interior pelvis at all. So the referral pattern. So where would we be getting some of that pain referred from the pelvic floor to the hip? And so I used this, I really like this article. It's already 10 years old and it feels like 10 years was like last year. But I really like it because they were pretty thorough but simple in describing where some referral patterns could be seen from the pelvic floor. So the study was conducted using, they had several patients. They had a group that already was diagnosed with chronic pelvic pain and one that was not. Okay. And the reason they did this is because they wanted to see what type of mapping they could do regarding pain. So they had the patients, the therapist or I think it was a physician, palpated and touched around different points of the pelvis. Now, their focus was mainly on bony prominences, okay? Not so much the soft tissue. And for that reason, I did add it here. But anyway, they palpated different bony prominences on there and asked patients, where do you feel it? And so they had a little diagram and they said, okay, point to where it hurts. And so they put little points and they did a pain map, basically, using the what they felt during palpation. So they mapped that out and they kind of saw a pattern of where patients were noticing referrals. Okay. So at the ischial spine, when that was palpated on patients that had that chronic pelvic pain, they described feeling discomfort at the groin, the pubic area, and the anterior medial thigh. Okay. Sound familiar? Yeah. Okay. The attachments, the soft tissue attachments, like the pelvic floor muscle, ligaments, and those, soft tissue structures are the coccygeus, iliococcygeus, and the sacrospinous ligament. All right. And those are in your pelvic floor. Now, when they palpated the ischial body and the ramus, the patients described feeling medial thigh pain and groin pain. Okay. And that is something that patients describe as like the inside of the thigh. And often, even if it's, more true OA, that internal thigh pain is really uncomfortable because often they are just kind of holding their legs together. They're not really moving that leg out as much because there's just no lubrication there anymore, to go full range in any direction, really. The attachments there are the OI and the adductors, the superior pubic ramus. So when that was palpated, groin, pubic region, and the lower abdomen was described as, that's where they were feeling pain. Again, adductors, inguinal ligament, puborectalis, and the some of our abdominal muscles. So the internal oblique and the transverse abdominis, and this is because they have attachments to that iliopsoas fascia. So where the iliacus and the psoas, dive and they become one, and you have some fascia there that helps kind of bring everything together. There is an attachment there from those abdominal muscles. So just kind of something else to think about regarding, when you see patients that are just that are describing, hip pain, don't bypass also taking a look at those abdominal muscles. Okay. All right. And then when they palpated the symphysis margin, patients described having groin pain and perineal pain. All right. And so the attachments there are puborectalis, pubococcygeus, superficial perineal muscle, adductor longus, and the gracilis. So if you have way to palpate some of these structures, the external ones, and I'm not saying you're going to be palpating, the iliococcygeus from the outside, but your adductors, your transverse abdominis, any of your abdominal muscles, even, those inguinal ligaments, all of that can give you a lot of really great information regarding whether or not that hip pain is coming purely from the joint space. Okay. So when you can, always palpate things that have a connection, have some sort of, crossroads there. And there's a lot of crossroads. There's a lot of shared tissue, shared, that posterior horn that basically sends a ton of information to that spine. So you have to kind of like pick at it a little bit to ensure that you aren't just kind of like blowing through your assessment and just labeling somebody a hip OA when in all reality they've got a few other things going on. Okay. All right. So who would be walking through your door? And based off of, kind of the projections regarding, the hip total joints, you're going to have a lot of hip replacements and hip OA and knee OA coming through the door. Okay, so you'll have your referral for a hip OA, what is it, treat and evaluate and treat. I chose a specific type of person that may be walking through your door simply because this is kind of the the person, the patient that seems to be not bypass, but almost it almost feels like, kicking the can down the road where it's hip OA. We're not going to do any, further assessment about it, and just go see PT, and we'll see how it goes. Almost feels like a dismissed type of population, and this is the older female. Okay, so and this happens not just for like orthopedic conditions, but for a lot of different conditions. And if you're, kind of have your ears perked up, there's a lot of talk regarding what hormones do, what we may have been missing in terms of diagnosis and treatment when it came to conditions that affect women. So, what unfortunately, tends to happen is that, we've got a female a bit older, over 60 years old, complaining of gradual hip pain, anterior medial thigh, deep aching at the hip. And, she comes to your door to be treated. You find out a little bit more about her. She had a cesarean, like 3 cesareans. She had a hysterectomy more than 10 years ago because, during menopause, or the beginning of menopause, she just kept bleeding and bleeding and bleeding. So, of course, the natural thing to do would be to do a, radical hysterectomy to make it go away. That's a topic for another day too, but the use of hysterectomy as treatment for bleeding is just crazy to me. So she's got also chronic constipation and stress urinary incontinence, right? You do your assessment, you palpate, the psoas is uncomfortable, the iliacus is making her jump all over the place. Hip internal rotation on the affected hip is 15 degrees versus 20 on the other side. It's not great on either side, but it's maybe nothing to write home about. External rotation, flexion are equal. Prone extension, 0 degrees versus 5 degrees contralateral side. Balance on either side, not great, something probably to work on. MMT also not great, but worse at the abductors. Okay, not really feeling much in crepitus, and the lumbar spine is negative. Okay, but she had X-ray that showed that she had some moderate OA going on. So if you are perhaps not a pelvic provider, you're not somebody that does internal work or anything like that, and a patient comes through your door with, the history that I just mentioned, I'm sorry, there are things that you should not miss, okay? Do not blow through these, okay? Number one is that hip abductor strength, okay? The reason for it is because that chronic Trendelenburg, that sway side to side, is killer on the pelvic floor, okay? There is strain and counter strain and lots of pulling and lots of attempt to stabilize, and you are going to feel it at the back, you're going to feel it at the hip, you're going to feel it at the pelvic floor. So always address those. And I think that we do a pretty good job as PTs in general regarding the abductors. However, just note that having that weakness is absolutely going to affect and influence the pelvic floor itself. Okay. Next is the cesarean. All right. Cesarean scars are huge. They're deep. They got a whole person out. All right. Doesn't matter that it was, it's a 20-year-old scar. It was probably never addressed. Probably nobody ever did anything about it. Likely it caused some sort of like synergy pattern, issues at the core, deep core, and they may have had compensations, funky walking, funky patterns for a long period of time because it was never really addressed. And if you ask them, if you just say, hey, how old is it? It's 25. My youngest is 25 years old. What did you do for it? Nothing. Just moved on like everybody else, like every other woman in my generation. It's, just live with it and go forward. So taking a look at what that core is doing, maybe what some of, that scar could be influencing is going to absolutely help a patient who is having some hip problems, okay? Now, constipation is also something to for you to pay attention to, okay? The reason is because you may now have an issue with how people are how they're feeling that intra-abdominal pressure, okay? And so if you've got a lot of that pressure in the abdomen, you're going to feel it in different areas, and it's definitely going to affect the pelvic floor, and it's absolutely going to influence where you may feel discomfort and pain, okay? So always address constipation as well, all right? The stress urinary incontinence, you should be addressing that as well, okay? Even if you're not a pelvic PT, and refer out if that is you've got somebody with hip pain who's got all these other pelvic conditions and history, and they've got stress urinary incontinence. I mean, don't waste time. Don't waste anybody's time. Send them over to somebody that's going to be able to help and integrate everything together. Okay, so you just have to do a really good job about explaining why you're referring, and we can go over that some other day. All right, and range of motion. How bad is it? All right. So, absolutely, if the range is, less than, I have some people I'm like, you've got no range of motion. I've checked you in extension, I've checked you in flexion, I've checked you in standing, and I mean, I can't give you more space in that hip. All right. And also check those adductors, because the adductors, when they give you any sort of tightness, and it's usually because they're weak, you're going to feel it right in the most proximal attachments. So there's a really cool way for you to do a little release in those more proximal attachments. And if you're interested in that, send me a message and I can share a video with you so that you can try that on patients. It hurts so good, when it's done on you. So if you have somebody with that, especially that growing pain, it's definitely something to do with them, and try to help and just give a little bit of relief. All right. So now if you're new to pelvic, or if you're more seasoned, absolutely, talk to the patient about, the surgery, because they're likely looking at, oh, I'm probably going to need a surgery, and let them know, hey, let's look at all of these other things to make sure that we aren't missing something, because I don't want to have you have a bad experience after surgery, or have a delayed, not healing, but just like delayed rehab where you're not feeling your best as fast or as soon as you should. And so, talk to them about that. And also any, you know, uh, make sure that you go over any bowel or bladder issues that may be going on. And if they do report that they have that, absolutely do not miss an internal pelvic assessment. Treat the OI and the adductors right away if you notice a limitation in internal rotation, because if there is some just like guarding because of something pelvic going on, when you kind of address these right away, and then you get mobility at the hip, especially in internal rotation, then you're onto something, and you're likely going in the right direction, and you're going into like really diving into the pelvic area. Okay. Address intra-abdominal pressure, of course, because that is just like a cascade of things. Just one thing can lead to the other, that can lead to the other. So ensure that that person knows about intra-abdominal pressure, why you're addressing it, what it can cause, and how to manage it properly. Okay. And then educate the orthos. I know it's hard to get in to see doctors or whatever. Figure it out. Okay. And we need to make this part of a just general PT. The fact that orthos send patients to prehab for PT is great. That's what we want. But we want to make sure that they're sending them to somebody that's going to perhaps be able to help them a little bit differently, maybe a little bit better as well, and can really, give really great results. And even if they do end up needing that surgery because the hippo is just hippo, patients are going to be more knowledgeable about their body. They're going to have better outcomes because knowledge is power. They're going to really trust you because they know that you understand the pelvis inside and out. And it's just, I think, going to make rehab just much better overall. Okay. All right. And so with the I guess overall, just kind of putting it all together, making sure that you don't skip things like the bowel and bladder questions. Okay, a lot of us, especially when we first start out and we're in outpatient settings, and there's no walls and everything is loud and everybody can hear each other breathe, you often don't want to ask, so are you, peeing your pants? Are you, are you constipated? And even if they are, they're going to say, no, 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 none of that. So putting all of this in the questionnaire. Okay. So if you have an intake that is kind of, just very, very just ortho, do you have pain here? Yes. Do you have pain here? And then you skip and bypass bowel and bladder, you're missing a lot. Okay. So overall, this is, a good intake will help you have a better plan of care. And if you have just a better overall understanding of where some of that pain may be coming from in the hip, you'll really be able to save that patient not just time but perhaps even money, because they're not going into surgery right away. So anyway, I hope that this helped out. I hope that you get a little bit from this and can utilize some of what we went over today in clinic tomorrow. If you are interested in that adductor soft tissue release, send me a message. I am my Instagram handle is at pelvic edu. My I do have my email address, I think, up in the notes, but it's Adriana, ADRIANAO at PTVIDA. So that's ptvida.com. Send me any questions you may have, or maybe anything that you would like to have clarified. But I'm really excited to be doing these. I know I went over a few more minutes again this week. This is how it goes for me. I'm always over, even with patients. I'm like, oh my gosh, I need to keep better track of my time, but I just have a really good time doing this. So I hope it was helpful and insightful, and I hope to see you again next week. We will be going over the third installment of the series, and we will be covering thoracic spine pain and how it may present and how it may be something related to, or maybe pain that's related to the pelvic floor. All right. Well, thank you so much. I hope you guys all have a